Welcome to the future of understanding. This is NeuroMind Insights, where we unlock the power of your mind.
We are looking at a highly potent, naturally occurring chemical structure. This specific molecular arrangement is classified as a tropane alkaloid. It is extracted directly from the leaves of the erythroxylum coca plant, a species native to the high altitudes of South America. When 19th-century chemists first isolated this alkaloid, it entered clinical medicine as a localized treatment. Its medical value stemmed from two distinct mechanical properties. It acts as a topical anesthetic, numbing tissue on contact, and as a powerful localized vasoconstrictor, rapidly shrinking blood vessels to halt bleeding. Because of these exact vascular properties, it maintains a highly restricted role in modern medicine, occasionally utilized during delicate ear, nose, and throat surgeries. Outside these controlled surgical settings, the drug transitions into a high-dose, unregulated system of widespread abuse. The clinical profile of cocaine, spanning acute organ failure to severe addiction, is a direct, unavoidable cascade driven by its specific molecular properties. These properties dictate how it absorbs, how it hijacks human neurochemistry, and how it induces systemic toxicity. In its most common, processed form, the drug exists as cocaine hydrochloride, a powdered salt. This diagram outlines its pharmacokinetic behavior. Cocaine is a weak base with a pKa of 8.6. Oral ingestion causes the molecules to undergo severe ionization upon contact with gastric acid, resulting in poor bioavailability. However, bypassing the gastrointestinal tract through mucosal insufflation or injection allows the active chemical to rapidly cross the blood-brain barrier. The pharmacokinetics change when the chemical state of the drug is altered to its free base form. By boiling the powder in water with a base like baking soda, the hydrochloride salt is chemically stripped away. Removing the salt alters a critical physical property of the molecule. Its melting point drops to 98 degrees Celsius. At this lower temperature, the remaining solid rock can be sublimated, turned directly into a vapor without burning up. Inhaling this vapor facilitates massive, rapid chemical absorption across the vast surface area of the pulmonary alveoli in the lungs. Shifting the route of entry to pulmonary produces the fastest possible neurological onset, compressing the time between administration and effect. This aggressive reinforcement of the reward circuit creates the drug's highest potential for addiction. Once in the bloodstream, cocaine acts as a severe central nervous system stimulant. It specifically targets the mesolimbic dopamine circuit, a region commonly referred to as the brain's reward pathway. Normally, the presynaptic neuron releases dopamine to reinforce positive behaviors, recycling it via reuptake transporters. Cocaine entering the synapse physically blocks these transporters. This mechanical blockade forces a massive accumulation of dopamine in the synaptic cleft. The neurotransmitter is released but cannot be cleared. This chemical bottleneck directly translates into the clinical symptoms of intoxication: euphoria, an inflated sense of confidence, and an excess of physical energy. On the extreme end of this dopaminergic overload, the patient may present with severe psychotic delusions and heightened aggression. One specific tactile hallucination induced by this state is known as formication, where the patient experiences the distinct physical sensation of insects crawling beneath their skin. This acute intoxication represents a forced mechanical failure, where the nervous system loses the ability to regulate its own neurotransmitter levels. Cellular damage begins immediately at the physical point of entry, occurring in parallel with the neurological surge. When absorbed through the nasal cavity, the drug's properties as a powerful vasoconstrictor take immediate effect on the local circulatory network. This diagram demonstrates localized ischemia. The constricting blood vessels actively starve the mucosal tissues of oxygen. Simultaneously, residual cocaine powder reacts with moisture inside the nasal passages. This forms localized hydrochloric acid, which actively breaks down the already compromised ischemic cellular walls. Over time, this combined vascular and acidic attack results in severe mucosal necrosis, often culminating in a complete structural perforation of the nasal septum. This rotting necrotic tissue then serves as a vector for severe opportunistic infections, such as invasive fungal sinusitis. The structural damage at the site of absorption is a precursor to the systemic cardiovascular strain occurring throughout the rest of the body. The drug triggers widespread vascular constriction, while simultaneously inducing tachycardia, or an abnormally rapid heart rate. This creates an extreme hypertensive crisis. Cocaine attacks the human vascular system on two fronts. It destroys tissue locally by aggressively cutting off blood supply, while forcing the heart to pump against a systemically constricted circulatory network. This combination frequently culminates in myocardial infarction or sudden stroke. Clinical interventions for cocaine poisoning are rarely isolated to a single substance. The drug is highly sensitive to co-ingestion, leading to synergistic toxicity. The most common and dangerous polysubstance combination is the concurrent use of cocaine and ethanol. This biochemical model shows the hepatic response. Processing through the liver simultaneously, they undergo a unique interaction. The liver synthesizes a distinct, toxic metabolite called Coca ethylene. While this extends the euphoric half-life, it significantly amplifies cardiotoxicity, drastically increasing the risk of sudden cardiac death. Beyond metabolic interactions, physicians must also account for external adulterants introduced during black market manufacturing. Black market manufacturing often introduces levamisole, a veterinary dewormer used to increase the drug's bulk. In human systems, the repeated presence of this foreign chemical triggers a sustained inflammatory response that often matures into severe autoimmune diseases. Recently seized supplies frequently show trace contamination with fentanyl. This highly potent synthetic opioid can trigger rapid, fatal respiratory depression, entirely masking standard stimulant overdose symptoms until it is too late. Treating acute cocaine toxicity means navigating a multi-chemical poisoning. The liver is actively synthesizing new toxins, while invisible adulterants simultaneously compromise the patient's immune and respiratory systems. The acute clinical presentation of a cocaine high typically lasts only 15 to 30 minutes, but the chemical's metabolic footprint extends far beyond that window. Metabolized traces of the drug remain viable for detection in blood and saliva for up to 2 days, in urine for 4 days, and can be trapped inside hair follicles for up to 3 months after ingestion. Once the drug finally clears the system, the biological mechanism of withdrawal begins. We return to the neural synapse model. As the blockade lifts, the brain initiates a defense mechanism against the recent forced dopamine flood. It physically reduces its own number of active receptors. This process is defined clinically as receptor downregulation. When baseline neurotransmitter function attempts to resume, the resulting deficit means there are no longer enough receptors available to receive normal, healthy dopamine signals. This severe dopaminergic deficit maps directly to the physical symptoms of withdrawal: acute fatigue, clinical depression, and severe anxiety. This physical rewiring of the brain is why recovery demands long-term group and psychological therapy. Repairing the mesolimbic circuit and reversing that receptor downregulation is a process that can take years. Cocaine is an aggressive pharmacological agent. It forces a transient state of neurochemical overdrive, but it does so at the direct, uncompromising expense of cardiovascular integrity, mucosal tissue viability, and long-term psychiatric stability.
Thank you for watching. If you enjoyed this video, please like, comment, share, and subscribe to NeuroMind Insights for more.